Candidiasis. Definition. Candidiasis represents an inflammatory reaction in the skin resulting from infection of the epidermis with Candida albicans. Clinically, the infection appears as a beefy red erythematous area with surrounding satellite papules and pustules. The pustules, when present, help in the diagnosis. In this section, candidiasis of the skin is discussed. Candidiasis, beefy red erythema with satellite papules and pustules. Incidence. Candidiasis can affect people of all ages. The incidence of candidiasis varies substantially by type of infection, ranging from over 1.5 million cases of invasive candidiasis globally per year to 75% of women experiencing vulvovaginal candidiasis at least once in their lifetime. Candidiasis is particularly common in diaper-clad infants and hospitalized patients. History. Patients usually complain of itching and burning of the skin. A moist environment is the most important local predisposing factor for the development of this disease. For infections in the perineal area, diapers and excessive skin folds help to provide this moist environment. Wet surgical dressings can do the same in other locations. On the hands, Candida albicans infection between the fingers occurs in patients who frequently have their hands in water, such as bartenders and dishwashers. In women with recurrent candidal vulvovaginitis, a history should be taken for predisposing factors, such as pregnancy, diabetes mellitus, birth control pills, and antibiotics. Candidiasis between finger webs. A. Beefy red erythema with desquamation. B. Macerated or moist skin presenting as a white patch. Physical examination. The most consistent finding in cutaneous candidiasis is bright red erythema of the affected skin, characteristically surrounded by satellite pustules and papules. Pustules are not always present but often their residua are noted. These appear as small, 2 to 3 mm, erythematous macules rimmed with a collarette of scale that represents the remnant of the pustule roof. As noted, the distribution of candidiasis favors moist areas. Perineal infection is most common in diapered infants and in women, in whom it is often accompanied by candidal vaginitis. In bedridden patients, especially those taking antibiotics, perianal involvement occurs and often extends up the back with multiple papules and pustules. Other favored locations are the intertriginous areas under the breasts, in the axillae, between the fingers, and under wet dressings. Note, cutaneous candidiasis is beefy red with satellite papules and pustules. Candidiasis, perineal location with satellite papules in a diapered infant. Differential diagnosis. The differential diagnosis depends in part on the location of the infection. In the groin area, candidiasis may be confused with tinea cruris or intertrigo, an irritant dermatitis caused by maceration and rubbing in intertriginous folds, usually the inguinal or submammary folds in obese patients. Compared with candidiasis, tinea cruris is much more sharply demarcated, and intertrigo is less likely to be so brightly erythematous. Neither exhibits the satellite papules and pustules of candidiasis. On the back of a bedridden patient, candidal infection may be confused with miliaria, heat rash, or folliculitis. In candidiasis, however, the papular and pustular lesions are usually accompanied by confluent erythematous involvement in the perianal and, often, perineal areas from which the infection spreads. A potassium hydroxide, KOH, preparation is negative for miliaria and folliculitis. Candidiasis developing under wet dressings can be confused with contact dermatitis. The finding of pustules favors candidiasis. The KOH preparation confirms the diagnosis. Intertrigo, an inflammatory rash that develops in body folds where warm, moist skin rubs against itself. Laboratory and biopsy. The important laboratory test is the KOH examination of scrapings from pustules or peripheral scale. If a pustule is present, scraping of its roof and contents has a high positive yield. The finding of hyphae and pseudohyphae is diagnostic for infection. Spores alone are not diagnostic, because Candida albicans and other yeast organisms can colonize skin without causing infection. For this reason, a skin culture for Candida albicans is less helpful than a positive KOH scraping. A positive culture from skin does not distinguish between colonization and infection, whereas the KOH preparation does, because the KOH examination detects the infectious filamentous form of the organism. It can be difficult, if not impossible, to distinguish between the hyphae and pseudohyphae of candidiasis and the hyphae of dermatophytic infections. Usually, however, the clinical picture is sufficient to distinguish between the two. A biopsy is not needed. Candidiasis. Note associated hyphae and spores. Inset, spores and pseudohyphae. Therapy. Candidiasis is best treated with one of the topical imidazole creams. Over-the-counter creams include clotrimazole, Lotrimin, and miconazole, Micotin. Creams containing iconazole, spectazole, and ketoconazole, Nizoral, require a prescription. The imidazole cream should be applied twice daily. The clinician should instruct the patient to apply the medication sparingly, because excessive application of creams to already moist areas can contribute to maceration and may cause further irritation. Widespread candidiasis is treated with systemic therapy. Fluconazole, diflucan, 150 mg once weekly for 4 weeks, is an effective oral agent but is seldom needed for local cutaneous infection. This oral agent is more often indicated for severe, persistent, or recurrent mucous membrane candidiasis. Oral ketoconazole is not to be used for candidiasis due to the risk of hepatotoxicity and adrenal insufficiency. Attention should also be given to predisposing factors, especially moisture. Drying measures depend on the situation. For example, an infant with candidal diaper dermatitis should have more frequent diaper changes, and a bedridden patient should be turned more frequently to increase air exposure to the back and buttocks. Note, topical medication should be applied sparingly. Note: widespread candidiasis is treated systemically. Therapy for candidiasis. Initial. Topical creams twice daily. Clotrimazole. Miconazole. Ketoconazole. Alternative. Systemic. Fluconazole 150 mg once weekly for up to 4 weeks. Course and complications. In most instances, response to topical therapy is prompt and, if the predisposing factors have been corrected, recurrence is unlikely. In patients with recurrent disease, both local, example, occlusion, moisture, and systemic, example, diabetes, immunosuppression from systemic corticosteroids, predisposing factors should be considered. Most patients with local candidiasis are not immunologically deficient, and the disease resolves with treatment of the infection and correction of the predisposing factors. Systemic candidiasis occurs exclusively in severely immunocompromised patients, particularly in those with hematologic malignant diseases. In such patients, the mucous membrane or cutaneous candidal infection may serve as the portal of entry for the systemic infection. Chronic mucocutaneous candidiasis is another rare disorder and represents chronic infection of the skin and mucous membranes in patients who are deficient in cellular immunity against Candida albicans. Pathogenesis. No special pathogenic strains of Candida albicans exist. The organism commonly colonizes the skin and bowel, particularly the colon. Pathogenicity in tissue is associated with the conversion of the organism from its yeast to its filamentous form. The most important local factor that encourages this conversion is moisture. Accordingly, skin folds are most commonly involved, as are areas occluded with wet dressings, including diapers. After penetrating the stratum corneum barrier, the organism elicits a complement-mediated acute inflammatory response that causes the dermatitis and prevents deeper tissue invasion.
Clinical case. A 42-year-old obese woman with poorly controlled diabetes mellitus presents with a 2-week history of an intensely pruritic rash in the inframammary and inguinal folds. She reports worsening after sweating and wearing tight clothing. On examination, there are well-demarcated erythematous moist plaques with peripheral scaling and multiple small satellite pustules around the main lesions. A whitish macerated surface is noted in some areas. What is the most likely diagnosis? A. Tinea cruris. B. Intertrigo. C. Miliaria. D. Contact dermatitis. E. Cutaneous candidiasis. Correct answer, E. Cutaneous candidiasis. Explanation. Cutaneous candidiasis typically affects warm, moist intertriginous areas such as inframammary folds, axillae, and groin, especially in obese or diabetic patients. Characteristic findings include moist erythematous plaques, maceration, peripheral scaling, satellite pustules/papules, highly suggestive. Why the other options are less likely? Tinea cruris usually has annular plaques with central clearing and an active scaly border. Satellite pustules are uncommon. Intertrigo, primarily inflammatory due to friction and moisture without satellite lesions. Miliaria, presents as small sweat retention papules or vesicles, not moist plaques and folds. Contact dermatitis, typically associated with a clear exposure history and eczematous lesions rather than satellite pustules.